Good morning, everybody. Thank you so much for being here. We were just talking about the fact that it seems completely impossible that it could be July 1st. And how did we get here so quickly? We're going to begin, as we always do, just taking a look at the numbers. And, you know, as we have for the last few of our virtual, just by looking at our overdose numbers, but as looking at our COVID numbers as well. As most of you probably saw yesterday, for the first time since March, the Commonwealth reported no deaths from COVID. So that is an amazing milestone, and one that we really didn't ever think we would get to, when just a few weeks ago we were still at a very large number. But the toll is still pretty staggering. We have to date in the Commonwealth lost just under 9,000 people, which I think at some level, because it became sort of just a drip, drip, drip every day, you really lose track of what that number looks like. And across Massachusetts, just under 109,000 people have tested positive. And of that, just under 24,000, so just about 20%, a little less than 20% of those cases have been here in Middlesex. So as always, things happen, excuse me, when greater numbers in Middlesex. So that has been true with the virus as well. And not to forget, there's just about 800 people still in the hospital being treated for the virus. So we are not quite out of the woods. One of the things, and yesterday I was speaking with our police chiefs across the county, talking about some of the things that we've learned from COVID, which, as difficult as this has been, have in some ways been helpful, and things we want to keep in place. For instance, you know, during the virus, we have not been arresting people for a number of crimes. We've just been summoning them to court, so they're being prosecuted. But we've been able to keep them, for everybody's safety, really, out of the police stations and out of the jail. And they've been arriving on a summons. And one of the things that's interesting about that, especially with respect to the other epidemic, that of some of the racist murders and incidents we've seen, is when you think about the number of people who are arrested, it is a very large percentage of those who are arrested for misdemeanors. And leaving out even the violent misdemeanors that would include domestic situations and the driving under the influence, where everybody agrees you have to take that person off the road. If you think about the host of low-level misdemeanors that make up the rest of the arrests that we make, and consider what the percentage is of those people who suffer either from a substance disorder or a mental health disorder. And then think about officers out on the street trying to get cuffs on that person, trying to put them in a cruiser or a wagon, and how things just can so rapidly go badly on the street. We have not seen that either. So when we think about how do we avoid having the kinds of terrible encounters that have happened in some other places, how do we keep people safer? What we've seen over these last 4 months is people have been getting summonses. They show up in court, they're being prosecuted for that offense, but we've managed to circumvent that whole process. That's the thing that we're really looking at seriously in terms of going forward. Another has been, as you know, for about 2 years now in Middlesex County, we have not asked for cash bail when somebody is arrested if we are not going to look for a jail sentence at the end. So if their crime is so minor that we would be looking for probation or a fine or something at the end of the day, we don't ask for cash bail, because we saw what the impact was of them being held, losing their job, losing their housing, losing their kids sometimes. During this time of the pandemic, we have been in an agreement with the sheriff, releasing some people to get the numbers down in the jail, both to protect the prisoners and to protect the folks who work in there from the spread that happens in congregate situations. That has meant that some people who we previously would have been asking for bail on we have been releasing with certain conditions, whether it's a GPS bracelet or they go into a treatment facility or something. We have been very, very carefully tracking those people because it's a public safety issue should they be out on the street. There have been some people who have managed to pick up another one of the same kind of crime. You know, they maybe pass another check, they've done something else, but we have been very fortunate in that we have not seen any significant public safety risk from that. And that has really made us think about, if those people were out with those conditions, could we use those conditions when the pandemic was over? Of course, there's a little more opportunity as things open up for people to be out and about and get themselves into trouble. But we haven't seen a dramatic increase in that, even as that has changed. So we're going to be looking very hard at that. Are there other ways to use house arrest, to use the bracelets, whatever, and keep people out while they're awaiting trial? And always balancing that public safety. I mean, there are obviously people, you know, throughout this pandemic, there are people that we have insisted for everybody's safety needed to stay in custody, and that is not going to change. But the question is, what's that number where you could do something else? So that's one piece. It has also impacted the treatment of people suffering from substance use disorder. Nora put a link in the chat box about a very interesting article that talks about the impact of increasing telehealth appointments and the prescribing during the pandemic that have really showed some of the things, again, like others, that you can change a little bit without causing a safety risk, that help people get access. That data seems to indicate that, unlike what we thought, for instance, if we were doing telehealth or we were prescribing some of the medication-assisted treatment, that you'd suddenly see more patients or longer prescriptions. That is not borne out by the data we've seen over the last 4 months. So what is really seems to have happened is that patients who might not have had access because maybe they couldn't make it to the methadone clinic every day, driving their kids and going to work and doing whatever, they now have access to treatment. So again, just things that we can hopefully learn from in all of this. With respect to the courts, and I know this is an issue for people who have pending cases, the courts, at least the district courts, are going to try to do a soft reopening beginning on July 13th. The pressure is still going to be on to do things remotely, but for people who need to be in the courthouse for some arraignments, we're going to be doing that. The much bigger challenge is going to be getting folks to come in to serve on juries. Obviously, people are not anxious, in some cases, to take public transportation, to be in a room with people they don't know, to be confined for a long time. So the court has said that it will not even try to do jury cases until after September 8th. And it's unclear what that opening will look like. There is some thought that we may not be able to do those until the end of the year. So we will see. With respect, as looking as we always do, not just to the people who've lost their lives with the virus, but with an overdose, we have seen, as of yesterday, from January 1st, we're now exactly halfway through the year, 90 overdoses across the county. We have seen what has not changed a great deal is the hardest hit place has been Lowell. We've had 17 overdoses this year in Lowell, 10 in Malden, and 28 of our communities. So we have 54 cities and towns. Just over half of the 28 communities have experienced an overdose. So that's sort of the update of where we are. The other piece that is extraordinarily concerning, you know, the overdoses have remained relatively low. What we have seen I'm not supposed to use words like alarming or concerning, but a significant increase in has been suicides. Many of which involving substances, but that number has really increased dramatically during this period. And I think for a whole host of reasons, some of which we know from the information we've gathered are very clearly connected to the pandemic in terms of people who've lost their job, lost their place of work, that sort of thing, their place of living, that sort of thing. All right, turning to our speakers, we have a great agenda today. We are very grateful to have here with us Deirdre Calvert, the director of the Department of Public Health Bureau of Substance Abuse Services. Deirdre's been with the Bureau for just a little bit over a year. She went there in April of 19. She is a licensed social worker who has experience in private practice and working with dual diagnosis patients, those with substance abuse disorder and some severe persistent behavioral issues. And as you all know, DPH and BFAS have really been the tip of the spear in terms of COVID. And I'm really interested, and I'm sure you'll join me in that interest in hearing from Deirdre about the implications of what I just talked about, COVID on the treatment of residents grappling with addiction. So Deirdre, thank you so much for being with us.
Thank you so much for having me. I really appreciate being here. And I'm so grateful that you brought up some of the telehealth and access to MOUD issues, because I'll talk about it in my presentation. So I did bring some slides to help guide us along to review what BSAS and DPH has done. Just as a reminder, oh, there we are. There's two sorts of flexibilities. They're the federal flexibilities, which we're incredibly grateful for, but we have no say over. And then we have the state flexibilities, which we do have some say over right now. So we'll go through. So next slide. And thank you, Nora, for being my tech person today. I appreciate it. So as you know, as many of you, you've been doing as much as I have, and we have of really trying to combat something that we have no experience with. It's not as if we have somebody saying, oh, I have 20 years experience in shutting down government and shutting this down and working with the virus. We're all trying to figure this out as we go along. So we've been incredibly grateful for the cooperation and guidance from the government as well as our stakeholders. So next slide. So some of the things that we've done, and I've kind of bucketed them into certain things, is we have given out, as of today, a little over 14,000 Naloxone kits. So we've given out 13,000 Naloxone kits to OTP providers. OTPs, as you know, are the methadone clinics. And if I speak in acronyms, please stop me and have me identify what I'm talking about. We are also in phase 2.0 of the Naloxone distribution. We are handing out another 13,000 Naloxone kits. As I'll talk about later on in the slides, we've allowed a increased flexibility around take-home medications at methadone clinics. So we want to make sure that as they're being able to take home this really indispensable gold standard medication, that they also have access to Naloxone. We also gave out, I believe, over 1,000, let's see, 8,000, excuse me, almost 9,000 Naloxone kits to emergency rooms and hospitals. And then we worked well with PARI, and at the beginning of the pandemic, we know that incarcerated individuals are being released, and we wanted to make sure they had access to survival kits of Naloxone, fentanyl test strips, and local resources. So to warm handoffs to OBOT clinics, which is office-based opiate treatment centers, which usually do the buprenorphine and Vivitrol, and also to any OTPs. So next slide. And stop me if you have any questions and if I go too fast. All right. Some of the things we did at the state, as I said at the beginning, some of the flexibilities the state allowed is we went through our regs with a fine-tooth comb to see what we could loosen or offer flexibility around to increase and maintain access. So we allowed staffing to census instead of licensed capacity. So for example, if because of staff members becoming sick, having to take care of sick family members or whatever reason, we didn't want a barrier to be that there was a lack of staffing. So to talk about staffing to capacity, if you're licensed for 40 people, we expect you to be staffed to 40 people, whether you have 40 people or not. So instead, if you only had 20 people in the building, though, you'd only had to staff to 20. So we allowed that flexibility. Any change of services, so if you had more people in your ATS and less in your CSS, we allowed you to flex those beds back and forth to allow for access without having to submit an amendment and go through a review process. We supported telemedicine practices across the board, and I'll talk a little bit about that flexibility as D.R. Ryan mentioned. Any space that was designated for any purposes, we allowed to use as isolation. We were having offices as bedrooms, as long as patients privacy and respect was given, we allowed any spaces to be used for isolation or quarantining. Flexibility around supervision of nurses, so we could continue to have the LPNs in, and any documentation we allowed flexibility in. Next slide. As DA Ryan mentioned, the flexibilities. So a little primer on OTPs. OTPs, methadone clinics, have not substantially been changed in more than 40 years. That means for 40 years we've been working with the same federal regulations. Massachusetts has been stricter actually than federal guidelines, and we are changing that, but we have aligned with federal guidelines. Through those federal guidelines, it's a very onerous process to get a take-home medication. And just to remind people, we don't have OxyContin clinics, we don't have Vicodin clinics, we don't have benzo clinics, but we have methadone clinics. And people have to take 4 buses, 10 trains, childcare, stand in line on Christmas morning, all of those things to get this medication that is legally prescribed. The federal government allowed us to give upwards of 28 take-homes, which was unheard of, or 14 days for people who are less stable. Less stable might be somebody who's housing insecure or who had a recent fentanyl or a recent illicit substance use screen. Before COVID, we had about 25,000 people at our 46 clinics, we had about 15.9% of people receiving take-homes. Since these allowances happened, we have about 60% of people receiving take-homes, which is amazing, and is allowed for social distancing. It's allowed for people to stay home and take care of their families. We require notifications if there's any med diversion, overdoses across the board. We've only received less than 40 complaints of lost or stolen or diverted meds out of, we're talking 16,000 take-home doses per month right now through COVID. So it really just points to the fact that some of these rules are incredibly archaic and that people are really rising to the level of responsibility. And we've also seen a decrease in no-shows because of the access to telehealth. People are more consistent, and the no-show rates for counseling have decreased dramatically. So that's my little spiel on OTPs. We also, for the OBOTs, because we were allowing telehealth, a lot of folks don't have cell phones or service, so we were paying for $80 per client for cell phones and services. For those OTPs, again, for that take-home medication, one of the federal guidelines is you have to provide a lockable container for them, and some folks can't afford that lockable container, so we were paying for those. And also the take-home bottles and casks, because now you had an increased amount of people actually using those take-homes. Both OBOTs and OTPs are being reimbursed for medication, because we are the payer of last resort. So if somebody doesn't have medication, or excuse me, doesn't have insurance, we will pay for that, those services. So next slide. Next slide. Oh, there we go. Good. Okay, perfect. So testing. So we also worked with EHS, who was incredibly diligent in doing mobile testing. So we worked with multiple venues and multiple agencies to ensure that anybody who had 1 staff member or 2 patients positive, we would test the entire program. So we worked on that throughout our congregate care bedded sites. That's any program. Congregate care is the word that EHS is using for any place that has a bed. So it'd be like ATS, which is detox, CSS, which is the step down from ATS, transitional services, TSS, or residential programs, any place that has a bed. Mobile testing as of June 17th, as you can see, was 772 people, and the breakdown between staff and clients. Next slide, please. So telemedicine. So as we've talked about, telemedicine has been a game changer. What we found, one of the flexibilities to the federal government was the allowance for buprenorphine to be begun or inducted via telehealth, which has allowed people who have never been able to access it through anxiety, depression, lack of transportation, insurance, to be able to begin buprenorphine via the phone. And right now, it's important to say, right now the allowance is also telephonic, which is just telephone. And then there's telehealth, which is the video HIPAA compliant. So the allowance is across the board right now. for people out in Western Mass who don't have access to high-speed internet in some locations or data services, being able to use their telephones has been also a game changer. We've seen decreases in, as I said, no-shows, increase in intakes, and remaining in treatment much longer. So we're collecting data on all this. We've also held weekly calls. Many of you, as I was looking around while DA Ryan was speaking, I saw many of the names that I recognized from our bedded calls that we had at the beginning once a week with Dr. Alex Wally, which we moved to every other week as the pandemic, as we got further along. And now they're going to be PRN as needed. Next slide, please. So as you are very aware, there's a huge disparity in accessing services, and COVID has really brought that to light as well. So we've reached out to minority representatives to ask how we can partner with them. This was in April. So we partnered with several places to ensure that we were accessing all of the folks that needed to be accessed for MOUD and also for COVID testing. Next slide, please. So reopening. Oh, I've said across the board, it was hard to close. It was hard to you know, at the beginning of COVID. It's been a lot more challenging to reopen because we're trying to do it safely. Right now, we are one of the states, if not the first state, in you know, in terms of progress. So it's a real testament to what Massachusetts is doing. So we have been involved from the beginning with making sure that our programs with visiting, with getting groups back up and running, all of the reopening of recovery coaching and recovery support service centers, and just trying to do it in a way where folks in recovery who need to recover in a community can do so in a community as much as possible while staying safe. So, and I can talk about any reopening guidances that we've done, but there's been many. Next slide, please. Oh, that's it. So that was my show. I'd love to know if there's any questions or comments or anything like that. And I really appreciate everybody's work in this field.
Thank you, Deirdre. Marion, are you unmuted?
Yes, I am.
Okay, good. I'm having trouble muting everybody and keeping the speakers available, so I'm sorry about that.
Yeah.
All right. Do we have questions?
No, I have 11:30. I mean, at 11:30, I'll go
Rita.
to water.
Okay. I'm going over this online. We're just talking to Erica.
Okay. Right. Well, there may be questions at the end, which would be great.
Yep. Good.
Right.
Thank you, everybody.
Our next
Hang on one
presenter.
second, Marion.
Okay.
Can I ask everybody to mute themselves, because I'm having trouble muting you.
There's plenty of food. I will plan on helping make salads. We always have everything.
All right. I'm going to try again.
If you need to cook, there's vegetables.
There we go. That's better. Okay. Our next presenters, Rose Gage and Jenny Smith, come to us from the Let Us Know Crisis Center. And LUK was founded in 1970 by VISTA volunteers. And for those of you who don't remember, VISTA was the precursor to AmeriCorps. And today they serve over 3,700 young people, adults, and families, with another 12,000 impacted by their prevention, education, and training programs. The agency has about 250 employees. They run 80 foster homes, 4 residential programs, and 6 office locations, including one in Lowell. In December of 19, LUK was awarded the Strategic Framework Partnership for Success grant through the SAMHSA. And this 5-year grant will allow them to create the North Central Community Action Team, NCCAT, which will focus on the prevention of alcohol, marijuana, and nicotine use among kids from 9 to 20. and they'll be serving 5 Middlesex communities: Air, Groton, Pepperell, Shirley, and Townsend. So Rose and Jenny are going to talk to us a little bit about the role of the grant in programming it in the context of the local impact and addressing behavioral and substance use disorder issues. So welcome, Rose and Jenny. Thank you so much.
All right. Hello, everyone. Good morning. We know that these are really difficult times for people, so we're honored to be here today to talk more about the grant. You know, as we also think about the new school year opening up and what that's going to look like for all of us. So I'm going to share my screen now.
There we go.
Okay. I'm Rose Gage. I am the Substance Use Prevention Coordinator at LUC, and I have been with the agency now for a little over a year. And when I started in this position, I tell everyone that we meet via Zoom, my first day was when we were mandated to work from home. So it has been very interesting to do community work via Zoom. However, I'm really proud of the work that Jenny and I have done. We have really taken this time to meet with a lot of individuals, and Jenny will talk more about the scope of our grant, you know, but we're talking to a lot of people. And that has been really interesting to get the pulse on what's going on around substance use issues. So I'm proud to be part of, you know, this organization. And what I really admire about the mission is, you know, how it says to challenge and inspire youth, adults, and families to realize their unique potential through community-based prevention, intervention, education, and support services. So we have important work to do, especially during, you know, these times. So I am going to have Jenny Smith, our substance use prevention specialist, start us off.
Good morning, everyone. I'm excited to be here today and talk to you a little bit more about the grant that me and Rose have been working on. It's been interesting times, so definitely challenging for community work, but like Rose said, we're making the best of it, and I think making some good connections and using this time to really get to know our communities a little bit more. So that's been exciting. And so the North Community Action Team received a 5-year strategic prevention framework Partnerships for Success grant through SAMHSA, so the Substance Abuse and Mental Health Services Administration. So we work closely with the Community Health Network of North Central Massachusetts, so the CHINA 9, and our goal is to provide prevention services and support, focusing on alcohol, marijuana, and nicotine use among young people ages 9 to 20 in our service area. So the service area includes 24 towns and 3 small cities including Fitchburg, Gardner, and Leominster. And then specifically for Middlesex County, we focus on Air, Groton, Pepperell, Shirley, and Townsend for this grant. Next slide. So here is a map of our catchment area. So you can see that pink is our west area, the green is our down south, and blue is highlighted as our north area. Right, so our work, so as part of this grant, we are doing community asset mapping and needs assessment. So really getting to know the communities, what services already exist, and how we can come in and not reinvent the wheel, but come alongside of our communities and help support the work that's already there. And if there's not already work being done, how can we start some of those coalitions? Also, we have been trained in some evidence-based curriculum to implement into schools and youth organizations. We're utilizing the positive youth development framework, so trying to get more youth voice into prevention work. We're finding a lot of times there's a lot of meetings that talk about young people and talk about the issues that young people face, but not always engaging young people in those decisions and engaging the voice. So we're working on increasing that across our region. Also implementing social media marketing campaigns. Those will be focused on youth and parents. for the prevention of substance use. We aim to support local coalitions, as I said, and if they are not existing already, seeing how we can help build new ones. The youth substance use prevention education for parents. So we also have a curriculum that is focused on our parents. And so watching for signs of substance use, what that looks like, and how you can support your young teen in positive coping skills. So as part of this grant, we're able to give out mini grants for youth organizations to do prevention programming or projects related to prevention. So those we're looking to release sometime soon. And then also part of this, we want to look at the policies and practices that are existing, how we can advocate for new ones and improve the ones that need improvement. Next slide. So what we've learned, Rose and I have had a lot of community meetings. We've definitely taken advantage of this time at home to set up meetings with a lot of different stakeholders, a lot of different sectors. We've talked to school resource officers, we've talked to principals, we've talked to community members, to parents, to law enforcement. And here's some of the themes that have come up as far as what the concerns are, and then what does the present look like as far as substance use. And it looks like we have some red scribbles here. I'm not sure how they got there, but adding to the decoration of the— I don't know. So we have school administrators and teachers are definitely concerned about the mental health of students. Oops, it looks like we skipped forward. Go back one slide.
Oh, sorry.
It's all right. There we go. Concern about the mental health of students when they come back in the fall. I think this is on everyone's mind. We know isolation is not great for the mental health of adults, but especially for our young people who are growing and need that social contact. So how are they going to show up in the fall when they're coming back to school, or how are they going to adjust to what the new norm looks like as far as our schools go? Also, we've heard across the board that vaping has increased dramatically in schools. Youth are even vaping in class and in the bathrooms because it's so easy to hide. And I think a vapor cloud lasts for a couple of seconds, so it's easy when teacher comes to vape and then turns around, cloud is gone, no one can see. So this is also concerning because as vaping becomes less and less easy to access in Massachusetts, are students then going to turn to cigarette use, or what does that look like? And then I think also a concern is the marijuana vaping too as part of that. And youth perception of harm of vaping is pretty low. So a lot of young people are thinking that it's just water vapor, or it's not harmful. And we know that is proving not to be the case. Same with marijuana, and the legalization in Massachusetts sends a confusing message to our young people in that it's legal and it must be good, or it's okay to use. And we know that the brain is still developing until age 25, and so smoking marijuana can have that effect on some of the brain development. And then we are hearing across the board from our teachers that there is an increased need for social emotional support in schools. And so it's so important, I think, especially as students show up back into the fall, that yes, curriculum and subject matter is important, but also we need to give them coping skills, to talk about anxiety and stress, to talk about some of the trauma that they may have gone through just being in this isolation period as a result of COVID. Some may be in not so great environments and being stuck in home with maybe an abuser or just a toxic environment. And how are they going to show up in schools, and how can we support them when they do? Next slide.
So I'm going to, finish us off with what we've continued to learn, or what we continue to learn is many youth are not using opioids. And we've met with a lot of individuals and parents like Jenny was mentioning, and this is a good sign. However, as we look at brain development and the use of, drugs and alcohol and how it affects the brain, these substances could lead to harder drug use. So it's really important that we're working, together on how to educate young people and really, prevent young people from starting to use some harder substances. The other thing that we're learning too is in-house school diversion programs are needed. The old ways of suspending young people for a week, unfortunately, is leading many to just go home and use. So what can be done to help educate young people, keep them in school, while also holding them accountable for what's going on. The Massachusetts Interscholastic Athletic Association, we found out, is also challenging schools to take more of a educational approach versus a punitive approach for athletes. We are seeing a high use of vaping and marijuana and alcohol with this population when they are not in season. So, it's still an issue, and they know when not to use and how not to get caught. Access to substance use resources, therapy, and treatment is really difficult in this region. It's, we've talked with folks, especially, in Middlesex County, around some resource deserts where some folks need to travel 45 minutes to Lowell or to Worcester in order to get the treatment that they need. And that has been challenging. In addition, more parent support is needed, as many don't know what to do to help their children who are using. So we've heard different things, that some don't know how to help, some are not admitting that their child has a problem, or unfortunately some are also using themselves. So that's where some youth are getting these substances from, either parents or older siblings. So what are young people saying? One of the best parts of our job is working with youth. Our backgrounds are in youth development, working with college students, working with teens. So we love having these conversations. And here are some quotes that resonated. Youth try drugs and alcohol because they want to look cool and give in to peer pressure. So that remains a really big factor. Many also want to quit, but need the resources and don't know where to find them. Another one, addiction runs in my family, so I know what the effects are and I choose to stay away from them. I don't use because I'm too busy with school and activities. So that positive youth development, those developmental relationships are key. Youth need help to develop stress management and coping skills. Especially now, there's so much competition. Our youth are so overly engaged and are extremely stressed out. And this time has not helped them either. And also, this was one that really stuck with me. It's important to ask youth why they're using before punishing them. So having those conversations that are not talking at the youth, but with them, to figure out what's going on is really important. All right, Jenny, you're up.
All right, so we asked the community what was working as far as practices that helped with preventing young people from using substances. So these are by no means evidence-based, although I'm sure some of them have been tried and true, but these are the opinion of our community members on things that they've seen work in their community. So they are saying over and over that starting prevention education younger, even as young as first grade, starting to have conversations about coping skills and social emotional support for young people. Educating youth on the biology of addiction and the effects on brain development. Educating school staff, teachers, and parents on the signs of use. Incorporating more social emotional learning in schools and youth programs. Implementing positive messaging campaigns. So they use the Proud to Be Me, substance free, so making it a point of pride for the young people who are choosing not to use. I think we've seen that the perception of use among young people because they think that everybody in the high school is using. They think everybody's drinking and doing drugs, and we know that that's not the case. And so the more and more that we educate them that it's actually a lot of high school students, middle school students are choosing not to use and choosing to live a sober life, and how to do that, and that it's cool to do that. The need for more after-school programs for youth that are not involved in sports. And so in a lot of our towns, there's a lack of resources for young people who are not on the football team or on the soccer team or not having a sport to do after high school. So how can we support some of our creative, more artistic young people and give them an avenue as well? So also mentoring programs, including peer mentorship, can be very effective. And so older young people kind of guiding some of the new freshmen in high school or whatever that might look like. And then also more education on healthy living, basic life skills. So they used even financial literacy, budgeting, cooking, some of those basic skills that we take for granted. I think we had one conversation with a community member that she said, wow, it's really great that I have this time with my kids because I can teach them how to use the dishwasher. And it's like something that we take for granted that kids should know, but sometimes there's just not enough time in the day to teach these things. And then also more school diversion programs was the last one. So what can we do? We know that suspension does not lead to positive outcomes for our young people. So what alternatives can we put in place that educate and divert our young people from continuing to use or continuing to take part in these behaviors, but is positive? All right, so we're looking for partners. We're looking to work together. We're looking for community members to talk to get more information from, to share resources, to get out into the communities more. We are, and I think I saw this question in the chat, we have been trained in life skills for middle school and high school students, also life skills for parents. So we are available to come out into the community or into local schools and teach this curriculum. We are hoping to eventually be trained as trainers, where then we can train teachers and staff and community organizations to implement this as more of a sustainable model. And then also we can do some one-shot workshops with prevention plus wellness for marijuana and vaping. For both middle and high school students. And the beauty of this curriculum is it also goes over like exercise and healthy eating. It's not just solely focused on the substance use. And so we have seen 87% reduction in substance use has been reported amongst middle school students after learning the life skills curriculum. So it is tried and true prevention curriculum. We are looking this summer to get out and do virtual workshops for youth and parents. So contact us. We'll have our contact on the next slide. And then also we would love to just talk to you all. Talk to you about what the needs are. How can we support your coalition? How can we support your community groups? How can we continue this work? And we also, something Rose and I are very passionate about is getting youth voice into these coalition meetings and things like that. And so we would love to work with you more on that as well.
All right, so finally, here's my contact information. So take out your cameras, take a picture of it, and I hope to have a very full inbox soon. But we're very excited to work with the community. We are working on putting together some of the most exciting Zoom presentations you will ever see in your lifetime, for our youth, because it's been interesting during this time. We've been told, wow, you really started during the worst time. You're not going to be able to work with anyone. And we really believe that there is work that we can do. So we're putting together these presentations, and starting to organize some of these workshops with different communities. So thank you so much for having us today. We really do believe that together we can change the world. Our youth need us, and we have some good opportunities to work together. So thank you very much. And we appreciate your time today.
Jenny and Rose, thank you. Questions?
So I put the contact information in the chat for folks that didn't pull out their cameras quickly enough. And Maria, I just wanted to call attention to Maria Ruggiero from up in Billerica posted some information about the program, the suspension program that they have up in Billerica.
Wonderful, thank you.
All right, next we have an update from our partners at Melrose Wakefield. You remember before the virus, in the days when we used to get together in real life, we would meet at Melrose Wakefield's facility at Lawrence Memorial. And that partnership is now a number of years old. That's really been an important partnership, both in terms of our task force and some of our other outreach efforts in the community. So in the context of some new construction at Lawrence Memorial, a new ambulatory service, Melrose Wakefield will be providing funding for a behavioral health coalition. And back in January, which feels like lifetimes ago, I remember on a very cold day, meeting with lots of community leaders at the hospital to begin that planning. We're very grateful to Eileen Dern and her colleagues for the initiative and leadership. And Eileen served as the Director of Community Services for Melrose Wakefield Healthcare, where they give direct service to thousands of families. And, you know, I really know firsthand from doing so many programs with her, Eileen has kind of got her finger in every program out there and helping people of all ages across the community. So we're looking forward to hearing from Eileen this morning about the status
Thank you.
of the new programs.
I really appreciate it. And I just wanted to mention today, I have some friends and colleagues with me on the call. Rob Bronia from our communications department, Karen Andrews from Community Services, and then Carol Plotkin and Dr. Danny Carlart have been really instrumental in helping with moving this initiative forward for the determination of need process, which is great. So thank you very much. Next slide, Nora. And Nora's my technical assistant for this morning. So just a quick look at our community benefits mission statement. And in this statement, we really want to be sure that the community understands that the resources we have, although they may be limited due to things like COVID, we are certainly out there acting as a resource and working with the community at all levels to really maintain services now during this pandemic, but also to continue and grow those services as resources are available. Next slide, please. So one of the things I think important to talk about as we start this conversation is we are definitely looking at healthcare in a very new way. And this is true across all of our colleagues and partners in the community, such as Cambridge Health Alliance, Mass General, BI Lahey. We're all looking at a combination of things that come together to bring a whole and healthy person. One of those is their physical health. Are they dealing with chronic diseases, things like diabetes and cardiovascular disease? Are they dealing with the mental health components of their life, maybe depression, maybe anxiety, especially during these times? What of those kinds of things that brings into healthcare now differently today, I think, than in the past, is we've really kind of partnered with the public health world to talk about those social determinants of health. As you were mentioning both in the prior two presentations, which were great, thank you, is transportation and being able to provide food for your family and having your electricity stay on. All of those things really impact the whole idea of what health is and what health means. And you'll see that in these connected bars, you'll see that some of the more high-level skills, such as having a sense of self and being able to control your environment and looking at how do you actually control your behavior, all of those things have really been thrown up into the air with this pandemic. One of my colleagues gave me a very great idea about a book I should read about managing when you don't know and leading when you don't know where you're going. And I feel like that every single day. It's trying to figure out where I am and who I am and how I'm going to lead to the future. Next slide, please, Nora. So Melrose Wakefield Healthcare, as all nonprofit healthcare systems in the United States, needed to do a community health needs assessment, which includes asset mapping and looking at the needs of the community. And even though this is an ambitious list, we recognize that these were the health priorities. And these were determined based on stakeholder interviews, stakeholder surveys, surveys done with community members throughout our 9 communities that we see as our community benefits service area. And these are phenomenal needs, and we're addressing them, some on our own, some at a very high level, some at a more deep level, and then some in partnership with other agencies across the community, such as public schools, faith-based organizations, other healthcare systems. And these are, as you can read, access to healthcare, chronic disease, disaster readiness and emergency preparation, housing and homelessness, infectious disease, mental illness, mental health, preventable injuries, social determinants of health, and including substance use disorders, violence and trauma, and working with vulnerable populations. And these are all things that we work on every single day, as I said to you, at a variety of levels. So doing some upstream work, talking about things like policy development, and then really working into the weeds of it by running a mobile food bank. Next slide, please. So in December, after finding out that these were our priorities, and depending on which group you looked at, whether it was looking at the stakeholders, whether it was looking at the community residents, they really came up with the same 3 highest priorities, and they were chronic illness, substance use, and behavioral health. And depending on which was which, behavioral health was either first or second for all those categories of individuals. And we decided as a group that we needed to really look at this in a deeper way, but we also recognized that we can't do it alone, and so that we need everyone's help in doing this. And I appreciate the DA's office and so many people coming in December and talking to us about it. And we asked 3 specific questions. What are the most notable barriers that impact the access to behavioral health care in our communities? And this community area goes from North Reading to Everett. It's lack of available providers for all ages, children, families, providers that would handle things such as substance use. So it was a variety of lack of providers. Housing and services for the homeless, certainly. Lack of communication between agencies and providers. And this was one where we might be able to have a better conversation, but we're limited sometimes in healthcare by HIPAA regulations, and then in some agencies just by who can we talk to, who do we have permission to talk to, and what are the rights of that individual citizen to keep their healthcare information safe and secure and confidential. Stigma and lack of education about what those available resources are. Insurance regulations, including ghost networks. So when you get into a system, a big system such as Mass Health, you might be told to call this particular agency. And I know in the case of Lifeline, we closed our base program almost 2 years ago, and we're still getting calls because those lists aren't updated regularly. And so people are very frustrated calling a place thinking they would have it. And thankfully, I do have a resource and can reach out and help them. But in many cases, you're calling and you're not getting a person or a number or anything, just an empty line that goes nowhere. Confusion about how to navigate the care. It's so complex and confusing. People have deductibles, they have co-pays. I'm getting to that age where I'm going to be needing to sign up for Medicare, and I'm going to need a friend to help me walk through this because despite being a nurse for more than 40 years, it's confusing and complex, and there are financial penalties if you do something wrong. And I don't want to not have the right care for myself and my family. Transportation, constantly an issue. Whether it's affording it, whether it's using a ride and getting to your visit an hour early and having to sit in the cold parking lot waiting until it's time for you to go in. Access to services for people with immigration concerns. They're afraid, they're very afraid of what will happen to them if they use the services that they're legally allowed to use. And really just what's going on in the medical community, lack of trust, feeling that if you come into the hospital, is someone else going to not serve you, or are they going to make a decision about you because of your race or your ethnicity or your immigration status? And a limited focus on alcohol-related programs. We've talked a lot about opioids and substance use, but in our area, alcohol is really the main issue. The next question we asked, and thank you, Nora, that's fine to go to the next slide, and these were the providers that were telling us what they thought. what populations did they feel were most vulnerable or at risk? Homeless, children, young adults, and children aging out of education and foster care, seniors, community members with suicidality and impacted by suicide, veterans, non-English speaking, rising risk populations such as grandparents as caregivers, trauma survivors, including both intimate partner and domestic violence, the LGBTQ community, and people with food and economic insecurity, as well as those people receiving mental health care and primary care. Okay, next slide, please. And yes, someone asked if I would share the slides. I'd be happy to. And the last question was, how could we as a health system collaborate with our community partners to improve behavioral health care in the community? So one of the recommendations was to spearhead a regional behavioral health coalition, and I'll talk to you more about that in a later slide. Participate in workforce development for behavioral health professionals, and we do that, but more definitely is needed. Share expertise with the community in a wide range of settings, increase availability of services, promote interagency communication, collaborate on expanded housing and shelter, improve transitions of care, and decrease wait times and levels of service in the emergency room, such as having things like a recovery coach, and enhance access to substance use treatment and primary care. And we are working on many of those initiatives right now. Next slide, please. So getting to this, as we did this work in December, and then we began to meet in January, February, and March, we had the insertion, as we've all talked about, of this pandemic. And I think the biggest things we see within our care is very true, and this information was gathered from the CDC. Fear and worried about a person's individual health and the health of their loved ones, worried about finances, job, or loss of a service that you may have had. Changes in sleep or eating patterns. I can definitely say I've done the COVID-19 and put on those extra pounds, and I've also not had a haircut or a color in a very long time. So there's lots of spraying of various chemicals on my head. Nora has brought us to worsening of mental health conditions, chronic health problems, increasing use of alcohol and substances. But despite all this, there is help available. Thank you. Next slide. So I'd like to tell you a little bit about what we are doing in response to COVID-19 at Melrose Wakefield Healthcare. And we are an active and proud member of an organization called WellForce. And WellForce is a compilation of community-based and tertiary medical center. So we have our floating hospital for children in Boston. We have Tufts Medical Center, Lowell, Circle Health, and Melrose Wakefield Healthcare, as well as a very large VNA, the Home Health Foundation, and a group of physician practices under Tufts Medical Center Community Care. So a very broad, rich organization that travels from the southern part of Maine all the way down to the Cape with providers and services for families. So the Melrose Wakefield Healthcare part of WellForce is turned itself around in about 2 weeks in the community, and in the meantime also provided that extraordinary medical care at the hospitals. COVID-19 testing is available in Melrose Wakefield area at the Lawrence Memorial site with a referral from a physician. We're doing safe inpatient and emergency care, and we really want people to know that. It's very safe now to come to the hospital, and we don't want people to be waiting for care because we know that that's critical to making sure that chronic illnesses and things like diabetes and a foot ulcer need to be treated right away, and those are things that can't wait. We are doing amazing amounts of telehealth. We were up and running in telehealth almost immediately, and it's been going very well, and in-person visits are starting again. We're supporting elders with monthly newsletters and check-ins and programming. We're working directly with all the senior centers in our area and the West Medford Community Center to make sure that those folks are getting the kinds of services that they need, and really working in partnership with Mystic Valley Elder Services on much of that. We're delivering care kits, food packages, clothing, diapers. Karen Andrews, who I mentioned before, who's on the call today, spends most of her day organizing supplies and materials. Last week alone, we were able to give out 45 bags of clothing for families who needed that type of thing in Everett and in partnership with the Elliott Family Center. We're providing WIC services by phone. We have the largest population of WIC families we've had ever, and it's all being done by phone by our staff. Childbirth and parenting programs are through Zoom, and we have resources through Constant Contact and Facebook. We're doing virtual home visits for young parents and groups, and we're supporting our community partners. Really, last evening did, 2 evenings ago, did something with our Malden City Councilor and one of our school committee members to talk about behavioral health with one of our psychiatrists, Dr. Ziotto. And also this great partnership with Elliot and the community services to be able to do multicultural, bilingual, bicultural play groups. So they're online and families can join and children can sing songs in their native language with speakers and characters. So we had a very large pink unicorn for one of our services last week, which was very fun. Next slide, please. And our next steps, and this is where we need you. We are collaborating on a regional behavioral health coalition with partners from the community. The Mystic Valley Public Health Coalition has agreed to join us. This is our public health directors from all the local cities and towns. NAMI, the National Association for Mental Illness, and DA Ryan and her team have offered to help put this together. And we're planning a fall summit. And this will be a hybrid model where we're all for some Zoom and then also have community locations for people that may find getting to use a Zoom call would be overwhelming. So folks like Jerry Whetstone, who runs our Malden Warming Center, he's willing to open up the church for the homeless population to come in and join us on the call. And we'll have that same opportunity with hopefully some of our other faith-based providers that might be serving the Haitian community, because Malden is, at least at the schools, the most diverse community in the Commonwealth. So really important. And we need your help. So despite these wonderful planning partners, the more of us working on this together, the better. So if you haven't been involved and you'd like to be, please reach out to me. I would love that. And as the DA said, we are building a lovely surgical center at the Lawrence Memorial Campus. And part of that process, and that's how I met Nora actually, was at the determination of need hearing, was that we agree to fund programming in the community and use some of the money from that joint venture to do that. Next slide, please. We're going to improve childhood resilience in schools. That's one of our funded items. So we'll be putting out an RFP in very soon. We're just waiting for final approval from DPH. Next slide, please. Reducing elder isolation is another agreement that we've made with the community. And next slide. And then really addressing stigma. And this will be another way in which we'll be hoping people will apply to do the kind of social media and training, because mental illness, as you can read, is an equal opportunity illness. And we're all impacted in some way. And before the pandemic, it was 1 in 5 adults, and it is much more today than ever before. Next slide. Any questions you may have? Ready?
Eileen, thank you.
You're very welcome.
Thank you. One of the things that Eileen's presentation brings up, and I just want to remind people, and we're happy to get you resources to the extent you can use them, is, as Eileen mentioned, you know, reaching out, doing services for kids. And as many of you know, this is the time of the year when normally I'd be spending a lot of my days out at camps and other things, talking to kids about water safety and windows and hot cars and all of those things. And one of the things that has been very concerning for us, and I think it is in part because everybody's been cooped up for a long time and they're just dying to get out. And also because with everybody home, people have gotten much used to sort of multitasking. But many of you remember this, from 2006 to 2012, that 6-year period, we lost in Middlesex County 33 children to water-related incidents where the children drowned, whether it was in swimming pools, bodies of water, ornamental water, all of those things. And, you know, that's something that really is totally preventable. And so we began a program in 2013 where over the last 7 years, and any child is too many, but we have reduced that number statistically to less than 1 a year. Of particular concern to us is we just passed the first day of summer last week. We've already had, fortunately, 2 near fatal drownings of kids, both at their own home in pools. And with the sort of uptick of people getting pools because they're afraid to go to beaches or public facilities, that kind of thing, we're very, very concerned about that this summer. So we still have all of those materials. We did a big push last week. You may have seen, we tried to get on every TV station to push that message out about people just being careful, being sure the gates are locked, really being sure that they're supervising kids actively at the pool, and not doing what unfortunately happens way too often. There's a whole group of people out there. I leave my child thinking, well, you're there, you'll keep an eye on them, without specifically saying you are now responsible for that child as well. So that's a push that we are really trying to make again, especially with the holiday weekend coming. So we're happy to share any of those materials, and Eileen's been with us at some of those fairs and things where we've done that. So that continues, probably increased because of the pandemic. Anybody else have any questions about Melrose Wakefield's commitment and the programs and the planning? All right, I know that Carrie Detremont is here from Lowell Health Alliance and wants to talk to us a little bit. I had a chance to see Carrie last night because the Lowell General is a magnet facility and they were having an evaluation last night. So lots of stakeholders at that, but Carrie has something to tell us about this morning. So, Carrie?
Morning. Yes, thank you so much for this opportunity. I'd just take a minute of your time to just let you know that the Greater Lowell Health Alliance, similarly, we have DON funds from Lowell General Hospital, and we distribute a request for proposal annually. This request for proposal is based on a process of community health needs assessment that we take the data and with much input from probably 100 different organizations, we compile a community health improvement plan. And part of that plan is to release a request for proposal to address those issues that have been identified in the community as greatest health concerns. So that request for proposal was just recently released, and the funds will be available for the fall. So the deadline of the request for proposal will be July 23rd. It's a Thursday, 4 o'clock, and it's a hard deadline. So please, if you have any questions, I did put the link in the chat for the application, so you can see that there. You can go to our website, you can actually download the application. But if anyone has any questions, they can reach out to me. My contact information is on greaterlowellhealthalliance.org's, our website there. There was a letter of intent that has passed, but that was not a requirement. So the application, if you see that there was a letter of intent, we just wanted to know about how many applications we were going to receive this year. So that's all I really wanted to say. Just let you know about that opportunity. Let me know if you have any questions, and thanks for the opportunity to announce this.
Thanks, Carrie. And Nora, who's keeping our chat going, also just posted the summer safety resources are out there. She's got links for all kinds of things, the Greater Lowell Health Alliance as well. Anybody else have anything they want to share with us, announcements? All right. Again, thank you all for being with us. We look forward to having a meeting within the next month. We'll send that out once we have everything scheduled. Thank you to Nora for making this all work virtually. And it was good to see everybody, even if only on the screen. Have a wonderful 4th of July, and thank you again to our presenters. Thank you.
Thank you all.
Thank you.
Thank you.